How do we change?
It's small, faster than huge residency.
Yeah, but we fit perfectly. It's exactly the right number of chairs.
I guess it's most people can.
Yeah, I think it's better. It wasn't fully my choice. Like they were like, you're really not big enough to have LH1 ever.
How does mouse?
Yeah, there it is.
Where, all right.
I think people pay more attention.
What was the other CBL was first?
Yeah.
How was that? Good.
Probably just have to start before everyone gets back.
Restart?
Yeah.
All right, we're gonna start. Does this work? No? Oh, all right. All right, we're gonna.
Hey, we're gonna start.
So today it's gonna be a little bit different. Instead of a bunch of EKGs, we're gonna go over basic ECG interpretation. So Felipe and Esteban can take a break if they want. Let's see. Part one of many. So what is the role of ECG in interpretation in the ER? For me, it's to quickly identify sick patients, narrow your differential diagnosis, and it's about a quarter RVU. So for those going in the community, it's a quarter RVU, it's $8. If you compare it to a prior, it's 2.5 RVUs. You get a repeat compared to that one before, it adds up, but not a county. And the county gets the patient to CPAP, but a little less important. And you have to do all this while, multitasking. So you're using a very small part of your brain to interpret something that can be, very important. So, the role of, learning how to interpret ECG, going back to basics, is pretty important. So you can do this very quickly and very accurately. All right, so a lot of times residents come up to me and ask me, what can I do to get better at EKGs? I say, you should read this book, and I send them the PDF, risking my, life giving a bootleg version of this book. And then they come back to me 3 months later, like, how do I get better at EKGs? Like, well, I just sent you this book, and I resend it, and this cycle goes on for 4 years. So I'm just going to spoon feed you this book. This is going to be like a 20-part lecture series over the next few years if I stay, but so we're going to go over basic electrophysiology. So this is like a med school level, okay? So you should know it. So this is the electroconduction system. It's basically a specialized group of cells that generate an electrical impulse. And it starts at the SA node and it spreads to the ventricles, to the myocardium. The SA node is the main pacemaker of the heart. Runs at 70 to 100 at rest. And it's located in the right atrium at the junction of the supravena cava. And it's supplied by the RCA most of the time, and sometimes the left coronary artery, and sometimes both. So, if you get MIs in those, often you'll get like, in RCA lesions, you'll get like kind of junctional rhythms or heart blocks. And that's kind of a component of why. So from the SA node, you have an electrical impulse that travels from the SA node to the AV node. And this is all in the right atrium. You have these internodal pathways. They're like conduction pathways. There's an anterior, middle, and posterior pathway. And there's also another pathway from the right atrium to the left atrium called the Bachman bundle. And from here, you enter the AV node. The AV node is located in the wall of the right atrium next to the coronary sinus and the septal leaflet of the tricuspid valve. And it basically slows down the conduction to allow the atria to contract. Without it, you basically would have atria and ventricles contract at the same time. You have dysynchrony, and that's bad. And this is mostly supplied by the RCA. And from the AV node, you have the bundle of His, which starts at the AV node, gives rise to the left and right bundle branches, and is located in the interventricular septum. And it's the only route of communication via the between the atria and the ventricles. The left bundle branch is it's located at the end of the His bundle and travels through the interventricular septum, and it gives rise to fibers that innervate the LV in the left side of the septum, and then it splits into the anterior and posterior fascicles. The right bundle, goes to the RV. It also runs on the right interventricular septum and terminates in the Purkinje fibers and doesn't have any fascicles associated with it. The left anterior fascicle, it's just one single stranded fascicle, and it innervates the anterior and superior parts of the LV. And the posterior fascicle is kind of like a fan that kind of innervates the posterior and inferior parts. And the left anterior fascicle, you can often see blocks, and the left posterior fascicle is pretty uncommon by itself to be blocked. Let's see. So there, left posterior fascicle. And basically you end at the Purkinje system, which is a bunch of individual cells that are just beneath the endocardium. They innervate the myocardial cells and initiate ventricular depolarization. All right, so this is an action potential. You guys remember which channels go through which parts? No. Doesn't matter? I don't know. All right, so I hear a lot of mumbling, so not really. So basically, you have a myocyte that's negative, right? It's at rest. You have cell membrane permeability, so you have some leakage, some sodium goes in, and basically you hit this threshold potential, and then a bunch of sodium comes into the cell, depolarizing it, and then you have some negative ions coming in, or positive ions going out in phase one, and then you have some calcium coming in phase two, and then you have more in repolarization, you have positive ions going out. And not that much important, but this cell permeability actually determines the intrinsic firing of the myocyte. So depending where you are, determines the rate. All right. So at the SA node, this goes a lot faster than the myocardial cell and the LV.
And before you switch the slides, just an important concept. Only the cells that are pictured there on the right have pacemaker capability, which means they have a phase 4. The regular cardiac cells don't have that phase 4, and therefore don't have pacemaker capability. So it's an important concept to understand is what can be a pacemaker for the heart.
All right. So each one of these cells has a vector. I know this is going back to math now. Basically, a vector is a diagrammatic way that represents the strength of electrical impulse and the direction. So these are two different vectors with two different amplitudes going in two different directions. And these are additive. So if two go in the opposite direction, net zero, right? Two go in the same direction are additive. And you have two going in opposite directions, so you have to split into two different components. So if they go in opposite directions horizontally, they'll cancel each other out, and then they're both going up. So they have a net upward amplitude. And basically the heart has like millions of these vectors, and then at any time, at any point, so that you have these cells depolarizing, repolarizing, and they create a net vector. At any given time, that's kind of the direction you create this net vector, and that's 1 point of a basic beat in the heart. All right, just one single point. So how do we measure that? It's electrodes. So if you have an electrode on the left here, and you have a vector going from negative to positive, let's see, you'll have a negative deflection because it's going away. And if you have one going in the middle, as the vector is approaching it, it'll be a positive way. As it's leaving, it's negative. And if you have one over here, it's only seeing the vector going towards it, so it's a positive wave. All right. And basically in EKGs, you have a bunch of electrodes at different parts of the heart, looking at the heart at the same time, and that generates an EKG. So do you guys know where the EKG electrodes are placed? The limb leads.
Like,
It's basically one in each extremity. Ignore the V right here. And then where the precordial leads. Shane goes. So you start in the fourth intercostal. Let's see. You have V1 at the right side of the fourth intercostal space, right of the sternum, V2 on the left. You have V4 on the fifth intercostal, mid clavicular, and then V3 in the middle. And then V5 is in the fifth intercostal space, interior on the anterior axillary line. And the fifth V6 is on the mid axillary line. So sometimes, especially at Kings County, every job is your job. And sometimes you got to discipline a patient. You shouldn't be really signing out an EKG. So if you can, just do it yourself. And don't tell Dr. Willis I said that. See. All right. So how do these leads create basically the leads you see on an EKG? So basically, from the limb leads section, they have basically electrodes have a negative and positive component, and they're able to create these three vectors. So lead 1 is going over here to the right, lead 3 is going down, and lead 2 is going down. Then it does some type of calculation that creates vectors that go through the middle of these vectors. And these create AVR, AVL, and AVF. Together, they create a coronal section of the heart. All right. These represent the left side of the EKG. All right. And the precordial leads create a transverse view of the heart. And these are on the right side. Okay. And together they create a 3D image. And here you could actually kind of localize, where we get the terms like inferior leads, lateral leads, septal leads. So inferior leads, it's pretty obvious from this graph here, or this picture, that they're 2, 3, and AVF anatomically. All right. So where do you guys think the septal leads are? So people are saying V1, V4. It's probably the septum's probably going around here. So it's like V1, V2. Anterior leads. V1 through V4, V3, V4. What about the lateral leads? So it's pretty clear here. So you have V5, V6. AVL, you can have, it's like high lateral, and then I think that's pretty much N1, right? And AVR is kind of reciprocal to all these. All right, now we're gonna go over the basic beat. All right. So each wave is basically a cardiac event, and each interval is a time in between those two events. So the P wave is basically the depolarization of the atria. The first half is the right atrium, because that's where the SA node is, and the second half is the left atrium. And then the Fergan wave is a TP wave, which is basically atrial repolarization. It's usually within the QRS complex, you don't see it, but sometimes it moves to the left and sometimes it moves to the right. So how would that change those segments? So if it was over here, what would happen? Someone says increased PR interval. This is a negative deflection. What would it do? It would cause PR depression, right? What about over here? ST depression. I think that's what people said. So sometimes at very fast rates, you'll get you might have atrial repolarization after, and it'll mimic a ischemia. There's no really good way to tell. You kind of have to look at the patient, right? All right, the PR segment. So I always thought the PR segment was just like the AV node stopping, kind of slowing down the conduction, but it actually has a lot of components to it. The AV node is one part, but it also includes the bundle of His and the bundle branches and the Purkinje fibers. All right. Let's see. And the PR interval is the total sum of the P wave and the PR segment. And do you guys know what the normal duration of that? Sorry? Less than 120? See, less than 200, more than what? 120. Okay, good. All right, and the QRS complex is basically ventricular depolarization. You have a Q wave. It's the first negative deflection. You might not always have a Q wave. and then you'll have a positive R wave, and the S wave is the first negative wave after the R wave. And you guys know the normal duration of that? That's the 120. All right. Good. All right. So the Q wave mostly benign, but can also be a sign of infarction. Do you guys know the criteria of a pathological Q wave? Someone said 2 without units. 2 Q waves. All right, so basically you're almost a box wide, a little bit less, and then if your Q wave is about a 1/3 the height of the R wave, it could be pathologic. All right. And then this is just intrinsic chord deflection. Is the QRS complexes the R wave is usually asymmetric. You have it's basically a little slower sloping up here, going up, and then faster going down. And V1, V2, you tend to have a shorter R wave to peak time, and V5, V6, you have actually V5 through V6, it's thicker because you go through the LV. This is not to be mistaken for WW. All right. And then the ST segment. What's the ST segment represent? It's our favorite segment. You guys noted in every single ECG interpretation. It's basically the time between depolarization and repolarization of the ventricles. All right, and this is where we look at ischemia. And the J point is basically where you transition from a QRS complex to the ST segment. All right, so then T wave is a ventricular repolarization. And this kind of you would think repolarization would be negative, right? But so basically, you think the first cells being depolarized would be the first ones being repolarized, but actually it's the last cells that are being depolarized are the first to repolarize. So that's why you end up with a positive deflection in T wave. Right? And T waves tend to be asymmetric. It's a kind of a slow upstroke with a fast downstroke. All right. And this would be symmetrical, would be concerning for pathology. All right, and lastly is the QT interval, which represents ventricular systole from the beginning of depolarization to the end of repolarization. And often this varies with heart rate. So it gets longer with slow heart rates and shorter with shorter heart rates, with faster heart rates. And how you correct for that is you can calculate a QTC, and there are multiple formulas for that. And the computer also can calculate it, but you should calculate your own if you're concerned. And sometimes you may see U waves, and these may be it's unclear what causes them. They can be caused by hypokalemia. They can just be there. All right. Often the presence of U waves can rule out hyperkalemia. It's pretty uncommon, but otherwise they can be benign. So they don't always represent hypokalemia. And the way we kind of determine where the baseline of an EKG is just from this textbook is actually they draw a line from TP to TP segment, because I think sometimes I find residents using the PR segment, but often it's depressed or sometimes elevated. So I just draw this line and kind of compare it. All right, so this is an EKG. The duration of an EKG is about 10 seconds, and if it's for each lead, it's 2.5 seconds. And each large box is 200 milliseconds, and each small one is 0.04. All right. And basically any point vertically is a complex occurring at the same point of time. All right. This actually took me a while to figure out in med school. I thought these are all simultaneously, but they're at different points of time. And typically what you'll see is normal calibration. So you have each large box is 10 millimeters high and 200 milliseconds. But you can recalibrate the EKG on Muse. One, to make it half. If you have very high voltages, you can make it half standard. Or if it's very fast and you're having trouble seeing P waves, you think they're there, you can actually slow down the paper rate to increase the paper rate from 25 is it millimeters per second to 50. So this is just an example. So you have, a patient with a large left bundle, you can't really tell if it's ischemic, it's coming off the paper. You can make it half standard to kind of give you a better, better view to interpret. Yeah. Here you have someone who's very tachycardic. You can't really tell if it's SVT, a flutter, or sinus tach. You can increase the paper rate, and now you can see flutter kind of P waves here. I have 2-to-1 conduction. All right, so there are multiple methods of determining rate. The easiest one, or maybe the second easiest one, is each big box is, you basically divide, you count the big boxes in between QRS complexes, and then you divide that, let's see, you divide that by the how many big boxes you have. So if you have one big box in between, it's 300, 2, 150, 175, and 60. You can do an even more intense calculation. You do 1500 and you count the small boxes in between. It's pretty tedious. But the easiest is, if you have a pretty regular rate, or actually you could just, since the EKG rhythm strip is about 10 seconds, the whole EKG, you could just multiply by 6. You count the QRS complexes, which might be tough if you have a lot. So here you have 18 R waves, you multiply that by 6, and that's 108. All right, so what determines normal sinus rhythm? What are some components of? Same P wave, same PR, and it precedes QRS complex. So yeah, you guys got most of it, but also P wave is upright in 2, 3, and AVF, which shows that's likely coming from the SA node. Here, if you look, if the SA node is here and it directs its impulse downward, the electrodes down the inferior leads will see a positive deflection. So if they're not upright in these leads, you may be looking at a pacemaker that's not in the SA node. All right, so got through some of the boring stuff, but now we're going to go through some EKGs. So we're just going to focus on P waves. All right, really basic, okay? So what do you guys think of this EKG? Do you guys see P waves? Yes. Do the P waves look the same in each lead? Yeah, there you go. Does each P wave is it followed by QRS complex? Yeah. And is the PR interval constant? Yeah. Probably if you had calipers, but they look pretty constant. And are they in the right direction, the inferior leads? Yeah. So would you say this is sinus rhythm? Yeah. This is like my 10th time using this EKG. This is like the first EKG on Dr. Silverberg's website, which you should also visit to practice. Let's see. All right. So this is the next EKG. What do you guys think? Do you guys see P waves? Do the P waves look all the same? Wow, such confidence. All right. Yeah, they look a little different if you look down here. This one's a little flatter. This one's peaked. This is smaller. Does each P wave have a QRS complex? Looks like it, yeah. And are the P waves upright in the inferior leads? I think for the most part, yeah. What about the PR interval? I think it changed. If you look here, this one looks a little shorter than this one over here. You guys know the diagnosis of this, just from the rhythm. So it could be MRT or wandering pacemaker, depending on the rate. I think the rate here is actually somewhere between 96 and 104. So it could be either. All right. So you have 3 different P wave morphologies. So you have different pacemakers and acting in the atrium. So this is like a supraventricular tachycardia. And here's just a diagram kind of showing this. So this is SA node, but if you have maybe a pacemaker here, it might be inverted. And then here the morphology might be a little bit different because you're looking at a different angle. All right, what about here? See, I see P waves. Someone says inverted. Where? Okay. And then is the PR interval constant? Yeah, it looks pretty constant. What do you think the diagnosis is? What's your differential? This is sinus? I think Felipe said ectopic atrial rhythm. Could also be junctional rhythm, but the PR interval is normal, so less likely to be junctional. All right. All right, next EKG. You guys see P waves? Yes. Are there P waves the same in each lead? Within each lead, do they look the same? I think so, they do. And are they up in 2-3 AVF? Yeah. Is the PR interval constant? Yeah. Do the P waves look weird? Yeah. So what do you guys see? Bi P waves. Are they? They're not biphasic, or I guess they're over here. What is this? P mitrale. What's P mitrale? P mitrale is basically, it's a sign of left atrial enlargement. The criteria are you have to be at least 120 milliseconds wide, and the peaks have to be about a box wide. All right, it's pretty uncommon, but it's pretty diagnostic of actually left atrial enlargement. I think it's very uncommon.
I feel like Basano, I see left atrial enlargement all the time.
Yeah.
I never see P mitrale.
It's an uncommon finding, specific but not sensitive. All right, what about here? You guys see P waves? Yeah, okay. Is this sinus? See a lot of head. And here you can, this is another example of P mitrale, 120 milliseconds wide and about a box in between each peak. All right. I don't know. Oh, actually, I do know. I wrote it in my notes. Let's see.
That's right, because then it's coming from the right side and it's spread to the left.
Yeah.
See that? Right, so if your left atria is larger, right, your right one's finished polarizing before the left side has. So if you have right atrial enlargement, I don't think I go through the text. But you'll just see like broader P waves, but it takes longer to start to the right.
I am actually going to go over it. Let's see. This is another example. All right. So what about here? What's going on here? Are there P waves? Does the P waves look the same? Oh yeah, they don't. Yeah. And are they up in the inferior leads? See some yeses, yeah. So the P waves look abnormal. People are saying, yeah. What makes them abnormal? Shane says they're pointed. What else? They look like QRS complexes, but they're not. So you see, this is the P wave here. They're really tall, right? They're like, 5 to 10 millimeters high. And this is the QRS. This is the R wave and S wave here. They actually look different. So what's the diagnosis here? So this is a sign of right atrial enlargement, but what else? What about the rhythm? So MAT, what do you think this patient might have? So they can have a P, but the MAT, maybe it's I can find something more chronic. A lot of these might COPD. It's kind of classically, this, I don't really see this often as well. But I think there is a.
All one, the bottom.
Oh, this looks different, yeah.
So even below the maybe notice.
Yeah, you see it here. So this is one QRS complex, and this switches here.
First right ball.
Yeah.
I don't know.
We're just focusing on P waves. Let's see. So yeah, this is P pulmonale. The criteria is you have to be basically P has to be greater than 2.5 millimeters in leads 2 and 3. And this is a sign of right atrial enlargement. And this is just another example. And another example. What else do you guys see here on the QRS complex? So you have enlarged P waves, but say if this patient came in with, let's see, shortness of breath. Yeah. And this is the right kind of right bundle-ish, right? You have tall R waves, maybe not wide enough, and they're anterior T wave inversions. So this is like kind of classically right heart strain. All right. Here, I think. Actually, so the P waves here don't quite meet criteria, but there's if you look at V1 here, they're biphasic. And what does that mean? Does anyone know? Someone says normal. It could be normal. All right, let's just go into. So this is a sign of intra-atrial conduction delay, which can be a sign of either left or right atrial enlargement. So if the upward deflection in a biphasic V1, P wave is greater than the first half of V6, then it's, it suggests right atrial enlargement. And if you have a big negative deflection in a biphasic P wave in V1, it's a sign of left atrial enlargement. Basically, if it's 1 by 1, it's pretty suggestive. There's like some calculations you can do. If you multiply, the width times the width and time and times the height, and it's 0.03, it's suggestive of like left atrial enlargement. But I don't think any of you guys are gonna be really doing that calculation. Just eyeball it. If it's 1 by 1 or it's at 2 by 0.5, it's probably right atrial enlargement or left atrial enlargement. So here you see biphasic P wave. Looks, what do you guys think? Is this left or right atrial enlargement? Look at V1 and V6. Yeah, if you were saying right, so it's positive deflection here is greater than V6. All right, and these are just more examples of biphasic. Is this left or right atrial enlargement? Left. So this is you have to have a positive deflection, but there's mostly negative deflection that's bigger than 1 by 1. So there's a sign of left atrial enlargement. And this patient probably has LVH as well. All right, what about here? Left or right? Left, yeah. So you kind of see the negative deflection again. All right, I think I'm running out of time, so I'm going to just skip over. Let's see. What do you see here? Left or right? Yeah, both. So you see kind of a P waves in lead 2, and then you have the biphasic in V1. All right. So you can, a lot of times you see both. You can have both, and why does any of this matter when you're looking at an EKG? Most times it doesn't, but we're supposed to be clinical monsters and you're trying to find a needle in the haystack. So I'll just tell you of a personal case. This is a patient I had, you guys are in service. It was just me and Hennison and CCT, because it takes 2 attendings to order MTP. That was decided last year. So they put 2 attendings on. And we get this patient come in, super short of breath, starting at 68%, B lines. We're like, oh, this is clear cut AP. The blood pressure is 170. We put him on BiPAP or an EKG. It doesn't get done. I give him nitrates. I give him Lasix. Put him on BiPAP. I'm like, oh, it's easy. Gonna admit this guy. I go to see him. He looks terrible. He's obtunded. He's sounding worse. His pressure is now 120. I'm like, oh, he should be better by now. I end up intubating him. actually before I intubated, got an EKG, got this EKG. I was like, oh crap. And because the trope came back 1. All right. So easy to see ST elevations when the troponin is 1. I called the STEMI code, and then ended up intubating the patient. And his pressure went from, he started at 170, 180, and after I intubated him, it went down to 40. I was like, oh crap. So we had to put him on presses. We transferred to Bellevue, awkward phone call to Bellevue, which almost killed this patient. What he ended up having is severe aortic regurg, or severe aortic stenosis. And if you look closely, maybe there's left atrial enlargement, which you can see in stenosis. And after we intubated him, I was like, this sounds like a valvular thing. Chris goes by, goes, oh yeah, this guy has a huge murmur. And I was like, oh man. I was like, you're the junior. You're supposed to be you're supposed to be looking at the murmurs. So he went to Bellevue, then he went to Tisch, got a valve replacement because he also had to get a cabbage for his triple vessel disease. But maybe we could have caught this a little bit earlier before giving him all these medications, right? That aortic stenosis, you're preload dependent, right? So basically we tanked him. We did everything to, kill the patient. Luckily, Schechter's not here. It's not going to give away the MRN. But it does matter sometimes in a sick patient. It's something to consider. It just helps you with your differential, right? Most times it doesn't matter. Most times LVH, right? And someone has, left atrial enlargement from that. Right? Because sometimes when someone's pulmonary edema, especially doesn't quite fit the picture, you should look for regurg, whether it's on echo. But not all attendings are, great at looking at regurg or stenosis, like myself. But maybe if you have Chris, it didn't even help then. So, yeah. Yeah. But yeah, that's pretty much it. You guys have any questions?